Welcome to everyone to the session. I'm Jim Bourgeois from Baylor Scott and White at Texas A&M in Austin, Texas. But my role here is as a parent of an Mpan young adult. And I'm just here to facilitate discussion of anyone with the researchers who are in on the call. Welcome to Allison, Susan, Penny, others who I may not know personally. Did you have presentations to make in terms of updates, or did you just want questions from people at this point?
So we actually had people pre-submit questions. So I have a list, and I thought we could start there, and then maybe when there's likely to be extra time where people can ask additional questions.
Do you have screen sharing, or are you just going to speak them verbally?
I'm just planning on speaking them verbally.
The old-fashioned way, okay.
Yes.
Well, if you're willing to start.
Can we confirm that Jenny is in?
She's listed as a co-host now on the side for me.
Yeah, there she is.
I just made her a co-host,
Okay.
so she should have.
Okay, she's
yep,
visible
there
now.
she is.
Hey, Jenny.
Hello, I'm here.
Oh, good. We're happy to hear you.
Yeah. Thank you.
Okay, so should we launch right in?
Yes, shall we begin? Go ahead.
Okay, so I see some people are still entering. We've got about 17 people here, and many of them look like my coworkers, not as many Mpan families that I recognize on the list here. But so as the families know, you had an opportunity to pre-submit questions a few weeks ago. So I took those and sort of synthesized them, tried to, combine ones that were similar. And I thought we could go through those. And just so you know, we have, especially for people who are new, we have Dr. Susan Hayflick with us, who is a pediatrician medical geneticist. We have Dr. Penny Hogarth, who is a movement disorders neurologist. And we have Dr. Jenny Wilson, who is a child neurodevelopmental specialist, so child neurologist and developmental pediatrician. I can see a few more entering that I recognize here. So without further ado, I will launch into some of your very good questions. I'm going to try to hop around between sort of different categories so we don't get too engrossed in one thing and go down a rabbit hole. But I'll start with a pretty general one, which was, what techniques can be tried to help keep people with Mpan fit? And I think this would both apply to children and adults. So I'm going to ask Susan to start with that one.
Well, I'm having trouble keeping myself fit, so I imagine that it's actually quite challenging. So I don't think that I have any grand insights here. I guess I would say that most people, including people with Mpan, have things that they like to do particularly, or they have things that feel like a reward, and so trying to tie some level of activity, whether it's walking or some water work in a safe setting, to tie activity with some kind of a reward. If the person doesn't particularly enjoy being active, that may be something that can support some level of fitness. Doing things with other people. So if they're a social person, that can be fun. If they have a sibling who likes to do something and they want to sort of go along, that can also be a sort of a reward type of thing. But it's a challenge for all of us, whether we have Mpan or not. And so I think finding ways to make exercise fun, rewarding, and sort of create kind of positive feelings around it, instead of kind of the sort of slog of putting on your running shoes or going to the gym or whatever. Making it fun, I guess, is what I would say.
Anyone else on the panel want to add anything to that?
So I'd just make a couple of comments that, and I think this will be a bit of a recurring theme. In Mpan, there are different challenges at different stages of the disease, I think. And so as the disease advances, and some people with Mpan will develop much more in the way of overt weakness as opposed to stiffness or spasticity, tone problems. And so I think the approaches are going to be different depending on the stage of disease, because once somebody has developed real weakness where they truly can't support their own weight, I think you have to be very careful about safety issues with certain types of activities. And so being very clear that what you are doing is not putting the person at any increased risk of falls with injuries is important in that stage. And so that's where, you know, Susan mentioned water exercise. I think when somebody has weakness, if you're concerned about trying to maintain their sort of level of fitness to the extent they're able at that point in disease, sometimes if you have access to water exercise is a really great idea, because the water will help protect them. That obviously needs to be in a very structured environment, and not everybody has access to that, I acknowledge. The other thing I would just say is that we all have to acknowledge that this last year has been very difficult, no matter where you live, I think. We have not had access to the same sorts of resources that we would have. And so I think a lot of individuals with disabilities of all types, Mpan and many different problems, have lost ground in this last year. And now we are things are starting to open up. I think trying to find those resources again will be key.
Thank you.
I think Jenny had some specific suggestions. I don't know if you want to speak to those, Jenny.
Yeah, I mean, oftentimes doing, like for children, doing community activities, sometimes that are more individual type sports, can be helpful to work on balance, agility, without kind of feeling the competition of other kids. So that could be like taekwondo or yoga, horseback riding. Those sorts of activities can be really good for working on strength and balance, and can be a real positive experience.
Okay, thank you. I'm going to move on to one that I think affects adults with MPAN more often, who are progressed in their disease, but it is something that comes up, and maybe I'm going to ask Penny to address this specifically, and then maybe more globally, because there are other things that happen beyond this particular question. But the question was, how do we deal with visual and sound hallucinations in an adult with MPAN? Someone who's sort of living in her own world some or much of the time. They're not problematic. They're generally sort of innocuous, but she's not quite with the rest of the family. She's having these other.
Yeah. So it is maybe a different approach. So hallucinations are not, whether they're visual or auditory, heard hallucinations. They're not a problem for every person with Mpan in adulthood, but they do show up sometimes in some people with Mpan, and sometimes they're not problematic. As this person has said, they're luckily mostly playful at the moment, but sometimes they can be quite troubling and quite scary. They can sort of agitate the person, get them quite upset. So I think the approach is going to be a little bit different depending on how bothersome they are. I personally would, I think, advocate for taking a light hand with trying to treat hallucinations that are not bothersome. Unless they're really starting to get in the way of family dynamics or are troubling to the person, I probably would opt on the side of keeping medications out of the picture, because as you know, anytime you add a medication, it can always complicate, you know, sometimes it can have unintended consequences. That said, if somebody is either really not interacting with the family much and you think it's because of the hallucinations, or even more challenging, if those hallucinations seem to be troubling to the person, they're upsetting, they're getting agitated, scared, anything like that, then I think there is a real case to be made for treatment. And the choice, there are some medications that can be quite helpful for this. Sort of the one approach is to try to give something that calms the person down. Those can be drugs that fall into a class of called benzodiazepines. They're Valium-like drugs. But they don't exactly, those drugs don't really kind of go at the target problem. There's another class of drugs that are used for hallucinations in other disorders that are called antipsychotics as a group. And while that's a scary name, there are some of them that are quite helpful in Mpan in this situation. There are also some, and this is worth taking note of, that are really quite high risk of causing more problems, particularly in Mpan, because they can worsen the Parkinson's-like symptoms that can show up later in disease. And so we want to try to avoid those if at all possible. And this is where close collaboration with either a movement disorders expert or just somebody who's got kind of deep knowledge of medication choice and will reach out if necessary to get advice about medication choices, because even within that class of drugs, there are some that are better choices than others. And so this is where I would definitely seek help from your provider. I think that's what I would say.
Is there anything else that anyone wanted to add? Just isn't common in kids, Jenny, but I don't know if you had anything. Okay.
Actually, just one other comment, I'm sure most people have learned this just in how they manage kind of family interactions, but sometimes diversion is a helpful tactic. So trying to divert the person if they seem to be very stuck and focused on a particular hallucination or a particular issue, diversion is sometimes, distraction is sometimes a helpful thing to employ just as a sort of behavioral technique, if you like. Sorry, Alison, go ahead.
No, that's fine. I think, while we're on this topic, I'm going to ask you one follow-up that's related since we're here, because this relates to the cognitive decline in Mpan in general that we see in adults. Hallucinations can be part of that, but there was also a question about what neurological drugs can help people with Mpan or could be taken preventively to try to maintain their function longer. And we don't have a lot of experience with that, but we have had a few patients taking that class of drug. Maybe you can touch on that.
Yeah, so that's a tough one because this is one area where as yet we have no data. We have nothing really to base it on except the stories that we hear from people. And stories are very powerful things, but we have to be careful about making general recommendations based on what we hear from one particular family that's been helpful. I do think there is merit to pooling experience with different compounds. There's not, so that is all sort of by way of lead in to say that there's not a specific drug that I could say, oh, everybody with Mpan should be on this drug because it is going to help your child, your adult family member with Mpan to stay fit for longer, to stay cognitively intact, to stay healthy for longer. I think in some ways there's almost more data for neurologic disorders in general, if we're talking about cognition, for ongoing sort of stimulation of the person, the making sure that they are not left out of family conversations, that you're kind of constantly trying to engage them and to, as we've already talked about, keep them physically active to the extent possible. I think those things play as big a role as any drug, and there's probably a little more evidence for their benefit. There are some medications that can help with some of the specific issues in Mpan, and I think we're probably going to talk a little bit about some of those tone issues and that kind of thing that I think can maintain function for longer. But there aren't drugs to prevent the cognitive decline, drugs that we have proven to be a benefit that can prevent the cognitive decline that is part of Mpan as the disease advances. I know that's not much of an answer, but I guess one thing I'd say is that I think people do try a lot of over-the-counter things. I think that it would be helpful for us to sort of learn about folks' experience with those, but I don't know that we've got really good data to support advocating or recommending one thing over another.
Okay, thank you. So I'm going to shift gears a little bit and direct this one towards Jenny first off. We had a question. Please recommend treatment for severe inward turning feet and shortened Achilles tendons, which are starting to cause pain. And I think, keeping in mind, we have people from different countries and different access to care asking these questions.
Yeah, I mean, I think if the turning in of the feet and the tightness of the ankles is impacting ability to walk and walk flat, then it warrants some treatment. The initial approach is a brace that holds the foot at 90 degrees if possible, but sometimes the ankle's so tight that somebody might not tolerate that brace. And then the options at that point are to try casting, doing sometimes serial casting to help basically get the ankle in a slightly better position by applying a series of casts over a number of weeks, and kind of depends on how significant the contracture is at the ankle and how old the person is, whether or not you try that. And then if the contracture is bad enough, significant enough that casting either doesn't work or isn't going to be an option, then sometimes people resort to surgery. If the foot is basically completely stuck. If the ankle still has some flexibility there, then hopefully those things can be avoided just by wearing a brace somewhat consistently to hopefully keep the ankle flexible. There's the other option of using a medication to help with tightness. And I think this is always tricky because it's not always clear how much benefit you're going to get at such a specific part of the body from a medicine that affects the whole body, and you're likely to get some side effects too. So I think you'd have to be real thoughtful about whether you tried a medicine, but usually we're approaching it first with an orthotic if possible.
Okay, thank you. Did anybody else want to add to that? That was pretty thorough. Okay, good. I'm just going to pause for a minute and let the participants know, because some of you joined late. I see a question in the chat about how can you participate if you're muted and your video is off. So we do have a few more questions that were pre-submitted. And once we get through those, we should have an opportunity for you all to ask additional questions because we should have time. I think you can ask your questions in the chat and I can read them. I think there may also be a sort of a hand raising function where we could have you ask it live. We'll have to see if our tech Trevor might be able to help with that, but we have about 3 or 4 more questions that were pre-submitted that I'd like to get through, and then we can make that shift. So with that, I'm going to ask, is it possible to improve balance in people with Mpan? Are there exercises for this? And I think I'll ask Penny and Jenny to both address that, for the kids and for the adults.
So Jenny, you want to go first for children? Because again, I think it is a pretty different question depending on if the person is still able to be safely up on their feet, just from a pure strength point of view, earlier in the disease and sometimes throughout the course of the disease, depending on, what flavor of Mpan the person has. The challenge arises from tone problems. And then it's a very different answer than when the challenge is because of weakness and other types of balance problems. So Jenny, can you tackle when somebody has tone abnormalities, what kinds of things can we do to help with balance?
Yeah, I think I agree. I think balance is complicated. It's not just one system that allows you to balance. And so This is where having a physical therapist involved to really kind of analyze and help direct a plan for each child is most helpful, because if, sometimes something as simple as trying a different orthotic can be super helpful with balance, or treating tight muscles might be helpful. On the other hand, sometimes the balance issue has more to do with weakness, or deconditioning, and then doing some strengthening and working on like very specific maneuvers with the therapist might actually be helpful in kind of practicing different balancing techniques, essentially. So sometimes the approach is kind of more environmental and, getting the right equipment for the child, the right orthotics. And sometimes it's more directed towards specific exercises to work on. But it's pretty child specific. And this is where I think most of us rely pretty heavily on a physical therapist to kind of implement the right plan for the right child, and hopefully somebody with experience with kids who have neurologic conditions. So yeah.
Yeah, so I would second that. I think there's three main challenges to balance in Mpan. One is tone abnormalities that tend to show up with sort of classic, typical Mpan that has its onset in childhood, spasticity, tone abnormalities, and that's where the things that Jenny's talked about, I think, can be really helpful. The physical therapist is your friend and will help direct that. Later in disease, either with adult onset Mpan, which is much less common, or with folks that have had their onset in childhood and are now reaching adulthood and developing more challenging problems, if you like. There are two problems that can show up in adulthood. One is this weakness, where you have a new kind of weakness that is really making it difficult for the information from the nerves to get to the muscles. The muscles are just frankly weak. And that's one issue. And then the other issue is that some, but not all people with Mpan will develop symptoms that look a bit like Parkinson's disease. And that in itself can cause independent problems with balance. And so exactly what it is that's causing the balance problem is going to dictate what type of approach you have. Jenny's already outlined what you would do for tone problems that are causing the challenge. When it is weakness, I think that's where things start to get a lot more difficult. Parkinson's-like symptoms, I think, can sometimes be helped by Parkinson's drugs. They can sometimes be helped very much by a walker, a wheeled walker. But those things are also dependent on the person having enough strength to use a walker to be able to benefit from those drugs. And so I think the approach is going to vary very much. Once somebody has become so weak, they really can't, and they're a big adult by this time, they really can't support their weight, they're going to go over and injure themselves. It gets to be much harder at that point, I think. But if they can support themselves with a really stable wheeled walker, sometimes with particular design features that keep them safe. For instance, if they want to fall over backwards always, I think that can sometimes be helpful to have a specially designed walker. And again, your physical therapist is usually the first stop, seeing a neurologist, seeing another provider, and then getting a referral to a physical therapist who can really sort of analyze what are the problems with this person's balance, and can I work together with the neurologist to try to find an approach that is going to work.
Okay, thanks, Penny. This next one I'm going to direct toward Susan, and I'm going to change it a little bit or make an addition to the original question. The original question was what supplements or vitamins can help maintain the health of people with Mpan? And I think it would be useful to address iron as part of that, because people do get concerned about iron supplementation or, iron in the diet. So maybe you can add that into the mix with that question.
Sure. So everything we know about Mpan today is that there are no nutritional deficiencies, and therefore they should be on a normal, healthy diet, just like all the rest of us should be on. With regard to iron supplementation, so this is true for Mpan and the other NBIA disorders as far as we know today, and that is that the brain that accumulates, the parts that accumulate iron, will accumulate iron sort of at the expense of the rest of the body. And so by withholding it, by either eating an iron poor diet or sort of striving to keep iron out of the intake, all that happens is that the rest of the body gets starved for iron, and that has actually quite serious complications. There's actually really old medical literature back in the days, in the 70s, 80s, or very early 90s, of some experiments that were done with the old kind of deferoprone-like drugs, chelators, that actually take iron out of the whole body, right? Deferoprone is a little bit better at focusing on brain iron and a little bit less at iron elsewhere, but taking the iron out of the body. And it caused quite serious iron deficiency and all of the problems associated with that. So what we know today about all of the NBIA disorders is that by limiting iron in the diet, we don't actually change the amount of iron that accumulates in the brain. And so for people who are eating a normal healthy diet or a full healthy diet and having sufficient iron in their diet, they should have a normal body amount of iron, and that can be checked pretty easily. If they are low, if a person with an NBIA disorder has low iron, especially if they're showing the blood cell changes that result from low iron and anemia, and some of the symptoms that come with anemia, they should take an oral iron supplement, just like anybody without an NBIA disorder would do, because again, the symptoms of low body iron can be quite severe and quite disabling. There's actually also really good literature that insufficient iron in the brain actually compromises a person's ability to learn. And so iron deficiency in very young children actually it can be quite a problem. So it's important that people with NBIA disorders and others have normal, healthy iron stores.
Okay, thank you. We've got about 3 questions left, and then I'm hearing from our tech Trevor that we'll be able to open it up for live questions. So next, and I think this will overlap with the dental session. For any of you who might not know, there is a specific dental session coming up later. But this is sort of a 2-part problem. So the question was, how do we deal with a constantly open mouth that is causing dental problems? So let's not talk about the dental problems, but about the open mouth. And I'm wondering if maybe Penny and Jenny have some ideas about what might be causing that and if there could be a way to address that.
Well, I hate to sound like a broken record, but I think it depends a little bit about what's causing the mouth opening. If it is dystonia or, a tone abnormality where it's sort of forced mouth opening, that can happen. Sometimes botulinum toxin injections can help with that. So this is a forced mouth opening where the message is being sent incorrectly to the muscles that do that. And so the person has their mouth sort of forced open. Later in disease, I think some individuals have sort of weakness. I think this is less common, but weakness that where the jaw is sort of dropping open, in which case simply lifting the jaw, you can see if that's the problem. If there's resistance, it might be a tone problem. If the jaw closes, then it may be that some simple mechanical solution, I mean, I hate to sound a little simplistic, but a wrap that holds the jaw closed might help. You do have to be very careful about making sure that the person can handle their secretions, that they're not going to bite their tongue, those kinds of things. I think more often it is a tone abnormality though, in which case sometimes Botox injections can help. I think it's also very important to be sure that you don't have a problem in the joint, the TMJ. Sometimes when people have had jaw opening for a long time, the jaw can partially dislocate, and in which case it's a whole different set of concerns. So the first order of business for this problem, I think, is a skilled dental person, and that's usually somebody called an oromaxillofacial surgeon. Not that they're going to do surgery necessarily, but it is usually someone who has the ability to look carefully at the joint, at what is causing the issue, because it is going to be very different. As Alison said, would really just encourage that you ask this same question and be prepared to get a totally different answer from somebody who knows a lot more about it than I do. I think this session is being done by one of the oromaxillofacial surgeons, is it not, Alison? I think that is just a bit later today, right after this session. So I might encourage you to attend that oral health session that is part of the general presentations, and to repose the question there and see what the oromaxillofacial surgeon recommends there.
I think I'm seeing something in the chat about the timing of that talk. Thank you, Sue. She's saying it's at 11 Pacific time. Right now it's 10 here, so an hour from now that talk will start.
I will just add that it's actually very important for dental health and the kind of the health of and longevity of your teeth to have saliva, sort of to be in a saliva environment. And so if the mouth is open, the saliva is being drooled, and the mouth is open, that has sort of a lot of sort of significant problems downstream. And so it is just acknowledging that it is it's an important issue to seek help for.
And we also prescribe medication for tone abnormalities, most notably Artane, that has this side effect. It's sometimes a benefit to families, but it is a side effect nonetheless of drying up secretions really quite markedly. And sometimes people are caught unawares by the fact that they now have new dental problems coming up because the secretions have been dried up. You know, the kids who have a lot of drooling, you can improve quality of life for the individual and for the family if you can help to dry up secretions, but it does come with some additional costs and additional need for very, very careful maintenance of dental hygiene, because you lose that saliva, as Susan said, you lose a protective mechanism for your teeth. And I'm sure that Mark will talk more about that at 11.
And actually, let me revise that. I just got another ping here. It's actually 10:45 Pacific, so 15 minutes earlier than we said previously for that dental.
Oh, okay.
That'll start 45 minutes from now. Thank you for those answers. We've got a couple questions left here. I'm going to direct this one to Susan. The question is, and I think others want to chime in on this as well. I'm in another country. Can we create an online network of experts in this field, share information from experts and families, such as descriptions and treatments used, research results, clinical trials, etc.? So maybe you can share with us your thoughts and pass.
It's a great question and it's a great idea. So I guess I would have two answers in general, and then I'll invite others to bring their views. But my two answers are, we kind of do it in a way already. It's quite informal, but there are mechanisms for physicians, for healthcare professionals, for families to quickly find, quote, the experts, whether they're in your country, in the country neighboring, or all the way around the globe. And so, I mean, every day, almost every day, one of us has kind of questions or comments, or, hey, did this medication work for this problem in this NBIA disorder? And so it is admittedly informal, but there is really sort of an openness among worldwide healthcare professionals to share information and to learn from each other and to assist each other in providing care, especially for people with rare disorders. So those of us who are either well entrenched in the rare disease community, or those who have a patient with a rare disease and are committed to their their best practices around their care, usually are kind of tuned in to how to find the experts. And we call ourselves experts, but that just is something that means we've been around for long enough and doing this for long enough that we've learned enough that we have a body of knowledge that somebody coming kind of new to the field might take them a while to learn. And so we have tried to download our brains, our collective brains, into best practice guidelines. And you know that we've published one for PCAN, and we are in the process with Jenny Wilson leading in the process of publishing one for BPAN. We need to do them for the others. We have one teed up for PLAN/INAD, and we need to do one for Mpan and actually the other NBIA disorders as well. So that's my first answer. My second answer is, I'm really interested to hear your ideas about what you think could work, and how you could make that sort of how you could drive that. So we all have to set our priorities, and the question is, could that be done by somebody in the community to create such a network in a way that actually serves the people who need it, and to fill a need that isn't currently filled. And so I guess I would turn the question back around to the person asking and say, what are your ideas? I'd be very interested to know them, and bring your ideas forward. So in the chat, there's also a global Mpan Facebook group, very active. That's a great way for families to communicate. Maybe there are scientists and physicians and other healthcare providers, therapists in those. For the most part, we don't, as a general rule, sort of guide care through Facebook. I think there's a lot of potential problems with that. And so a Facebook answer, in my view, probably isn't a viable solution, but I'm really interested in hearing from people.
Thank you. Did anybody else on the panel want to join in with additional comments about that? Not right now. Actually, I was going to ask you, James, as a parent of a woman with Mpan and as a physician, do you have any insights into this question?
Oh, sure. A lot of times we find we're instructing our daughter's physicians in the subtleties of this, because everyone we've met, except for the geneticist that discovered it, no one is really familiar. That's understandable. So you need a sense of collaborative partnership, if you will, where you can describe your observations and engage your care providers in a collaborative way with, how can we work on this together? My daughter's most recent primary care doctor was quite curious and took this on, and we had a single consultation with a geneticist at my place, and the geneticist was not familiar with it either, which isn't a surprise either. But we were able to put together a really nice plan with a regular podiatrist, regular physical therapist who work on her extremities problems, a pediatric dentist who's able to look after her dental needs. And all the time you're having to communicate what you know and have learned, and sort of get feedback from them and get everyone assembled as a kind of a team rather than a single individual. I found that helpful.
Thank you. I'm sure we'll have more discussion about this when we open it up in a minute here. And then
You
our
know,
last question.
Just a quick comment on James's point that people often ask us, who is the Mpan expert in my city? And often the answer is, I'm not aware that there is one, but I think you can get very good care from a physician who is curious, as James just pointed, curious and interested in learning. I mean, that person can be a partner with you in listening to you, learning from us, learning from others, and learning from your child, your loved one, and providing really excellent care.
And it's a hard answer to hear, maybe, but the answer to that question is you are probably the expert, the Mpan expert in your city. You probably know more about Mpan than anyone else. And so I think it is a very counterintuitive position to be in, to be the one educating a provider. And, just add a third call out. If you've got a curious provider who can be your partner, they can bring medical expertise, but you as the family are going to be the one that will educate them about Mpan in general, point them to the appropriate resources that they may not even be aware of. And then also layer on top of that education about educate the provider about your particular family member, because Mpan, just like all of the NBIA disorders, is variable. And that provider almost certainly will never have seen an Mpan patient before and may never care for another one in their professional lifetime. And so they have this opportunity to be your one-off physician, which comes with some costs, but it also comes with some benefits if you've got the right provider who is curious and who will partner with you. So encourage that.
Thank you. One last question here from the pre-submitted questions, and I'm going to direct this one to Penny as well. And I know you have caveats because this is a pretty general question, but it's, should we do DBS for Mpan?
Yeah, the short answer is probably not. So there's not good data, very limited anecdotal data, and that is not positive for DBS in Mpan. So there's a rationale for thinking about it, because when people with Mpan develop Parkinson's-like symptoms, deep brain stimulation was originally developed to treat symptoms of Parkinson's disease. And so it was reasonable to think that deep brain stimulation should be helpful in Mpan. I mean, that's a logical thing to think. However, we know also from the Parkinson's disease experience that deep brain stimulation, when it is done in a Parkinson's patient, this is straightforward Parkinson's disease now, when deep brain stimulation is employed in somebody who has even a fairly mild degree of cognitive challenge, their cognitive function kind of tanks and gets a lot worse. And you might get some brief benefit physically, but it comes in Parkinson's disease at a cost of cognitive decline. That does not seem to be the case when somebody's cognitively intact, when they have normal cognitive function, but it does seem to be the case in Parkinson's disease with cognitive decline. So for all of the NBIA disorders that feature cognitive challenges like Mpan, we are very, very hesitant to recommend this big surgery. Many of the risks of deep brain surgery, stimulation surgery, come at the time of the original surgery. There's a risk of brain bleed. There's a risk of infection, needing to have the device taken out. It's very difficult for somebody who is as impaired as most Mpan patients are to be in a hospital setting, an acute care, intensive care setting for an extended period. They can't cooperate with programming, the extensive programming that is needed. And I think that it is probably a much greater risk than any prospect of real benefit. That said, We don't have data in Mpan. And so if anybody does pursue deep brain stimulation, we don't want that experience, good or bad, to be lost. We want to hear about it. We are not, in our group, not recommending it. I think that we've all felt that the risks outweigh the potential benefit.
Okay, thanks, Penny. So we have about 15 minutes left. We have 22 participants in this group. So we're a small group, and I can see that more than half are clinicians and people from our team at OHSU. So I think we have a handful of families. We'd like to be able to have you ask questions live and have a little bit of dialogue, but we're going to need to be careful not to talk over one another. So Trevor, can you tell people how to raise their hand using the reaction? I don't see a hand raised there. I see some other little emojis, but if you can briefly give us instructions.
Sure. It probably depends on which version you're using, but if you do click on the reaction thing, there should be, it just says raise hand. If you don't have that, then you can actually unmute yourself and then remute yourself after your question is asked. Some of you might have a little 3-button thing here with more options. So some of you might have raise hand in there, but that looks like just emojis. So it kind of depends on which version you're using. But if you don't have the raise hand thing there, then just go ahead and just directly type in a chat question or unmute yourself and verbally ask.
And if they do raise a hand, where are we going to see that? Does it show up next to their name on the participant list?
Yeah, it should. So, okay, so I just made it where everyone in the audience can unmute themselves. So you can either chat or verbally ask a question.
Okay, so we're glad to have you here. I know some of you are in other countries and other time zones, but you know, you've got about 15 minutes to talk to the experts here if you do have follow-up questions or want to make a connection.
And for our European participants, you know, it is not a surprise to me that there's a really active, there are really active groups in Europe. There are more people with Mpan in Europe that we know about than in the US. And some of that is because of this, what's called a founder mutation in Poland. And so Poland, Germany, I think has many more Mpan families in that part of Northern Europe than we know about anyway in the US. The group in Germany, in Munich, Susan, is it? Mm-hmm. Are, you know, really getting their feet under them to, I think, lead research in this area and have, you know, a very active role in Mpan research. And so, you know, we're very welcoming of that. We will help in any way we can. I just would sort of point out that even in the US, I think that we should be watching Europe very carefully for developments in the research realm in Mpan, because I think they're better placed than we are in some ways to do that research.
Hey, I'm watching all of you, but I don't see any hands going up. Is there anything else from the panel that anybody wanted to add, or James, anything that questions you identified along the way that we should be talking about in our last 10 minutes here? Oh, here's a chat question. This is from Tatiana. What can be done with stammering? So this is related to speech. Penny and Jenny, I'm going to kick that one to the two of you.
So I'm inferring here, I might be wrong. Sometimes there's a kind of a stammering speech that can happen that is related to the Parkinson's-like symptoms. It's sort of analogous to, similar to when people's feet get stuck in place and they have a sort of a pitter-patter to their feet and they can't get started. the same sort of thing, we call it freezing or start hesitation. You could think of that as what is happening with speech. Now, the bad thing about that is the drugs that sometimes help with the pitter patter of feet don't help with the voice problems. Just things that we have heard anecdotally is sometimes families tapping out a rhythm when somebody is trying to get started on a phrase, physically clapping and trying to get them to speak to a rhythm. I'm singing will help them overcome the stammering, but it is a tricky problem. And I'm not sure I'm answering the question that is being asked because I'm not really sure about the age of the person, etc. But Jenny, do you have anything from a pediatric perspective? My perspective is mostly in adults, tapping on the leg to try to get a rhythm going. And that is something that has to be practiced over and over and over again with someone who is cognitively impaired. But we have seen that be helpful in some instances.
I don't think I have much to add. I mean, I don't see it quite as much in kids. And usually I'm kind of working with our speech therapist to take a look and see what's going on and offer some techniques.
Okay. We do have a question here from our friend Fatme in Switzerland. Hi, Fatme, I'm glad you're here. She is asking if a baclofen pump is recommended for Mpan patients. And maybe you can clarify for us if you're thinking at a certain age, Fatme, and then her follow-up is when is the best time or best stage? Okay, so this answers it. What is the best time or at what stage in Mpan would you consider doing a baclofen pump?
Jenny,
yeah,
that is all yours.
Yeah, I mean, with baclofen pumps, I would say I've learned over the years to be awfully cautious with them, and I'm using them in individuals with severe spasticity or dystonia. So the increased tone due to muscle tightness, either spasticity or dystonia, has to be pretty significant and not responsive to other treatments. So it's not usually something I'm jumping to early. So, the question I think is, what are the goals and will the pump actually achieve those goals? So that is really pretty key to elucidate with therapists and family members is, what are we going to get from reduction in spasticity? And is that, is a pump really going to get us there? And is it worthwhile? Because a baclofen pump comes along with quite a number of risks. There's some upfront risks with the surgery, but it requires a fair amount of visits to a physician to get refills. And there's a fairly high complication rate, at least in children, it's as high as 30% with baclofen pumps. And when they go wrong, they go quite wrong. So, yeah, I think there would have to be fairly significant spasticity, and dystonia is actually an off-label indication. So I'd be cautious, I guess.
One other comment on that sometimes the spasticity in a disorder where there is both spasticity and there may be weakness, sometimes the spasticity actually helps a person, helps to sort of balance out the weakness in the sense that it keeps somebody able to do something, maybe stand or walk with some assistance for longer. And so it's really important that in a disorder with weakness like Mpan, that is considered in the balancing. Because if you then take away much of the spasticity and the person is very weak, then they suddenly are way behind where they were before the baclofen. James, yeah.
I would just reinforce what Penny said earlier about DBS, which is the cognitive risks of the intervention, be it baclofen or DBS, has to be strongly considered.
Good point. Thank you. I don't see any other questions. We have about 5 minutes. If anybody else wants to submit something in the chat or, oh, here we go. Fatma has another one. Is there a distinction between early and late onset Mpan? That's a good question. I think Penny or Susan, you could tackle that one.
Yeah, why don't I take a first run at it? I don't fully understand the question. Is there a distinction between early and late onset MPAN? Well, early onset is early and late onset is late. So there is, but you've answered your own question. Early onset MPAN is meaning it has its onset in childhood in the first and a half decade of life, is what I think of as classic MPAN. Separately, there is this kind of MPAN in a person who seems to be doing just fine, living a normal, healthy life, having a family, working, and then sometime in their adulthood, 20s, 30s, 40s, 50s, there is a rather catastrophic sort of event that it turns out is the MPAN disease itself. The person begins to have prominent dementia, Parkinsonism, and it seems that the course of that disease usually is very, very fast in its progression. That is a rare kind of MPAN, but we have multiple experiences of individuals with that. So Fatima has clarified, I mean disease progression. Like with all of the NBIA disorders, the early onset, the earlier something has its onset, usually the more rapidly it is progressing. The later something has its onset, the more slowly it is having its progression. However, just told you that in this kind of precipitous MPAN of mid-adulthood, it's really a very, very fast decline that is really something we don't understand.
Yeah, and I would add to that, because this is making me think of our dominant MPAN paper, Susan. We did have a paper come out a few years ago. You know, we'd been studying a few of these families, which were very unusual, because usually MPAN is recessive, meaning it comes from both parents. They each carry the gene. You usually don't see it in multiple generations because of that, but we did have a handful of these families with this late onset, very sudden, rapidly progressive form that were dominant, where we were seeing it in multiple generations. And, you know, most of that is because these adults were living their lives, doing their thing until their 20s or 30s. So they had the opportunity to, you know, marry or find partners and have children. So you do see it being passed on because it happens to be dominant in those families. The dominant form can also exist in the early sort of classic form that we see. But that's been, you know, very new information to us. So we're definitely still learning about MPAN. Anyone else? There are no other questions being submitted. We've got about 2 minutes. Maybe I can ask James to just wrap us up as our moderator.
Well, thank you everyone for your attention and your questions and discussion. Thanks to the panel of experts for participating in such an interactive sort of forum. I think ultimately these are things we all have to work on together, both sharing with each other and within families and so forth. And part of what we take forward is what we tell the other people in the medical community, and keep raising awareness and looking for ideas and sharing them through forums such as this. So thanks everyone for taking the time, and I hope you enjoy the rest of the conference and find it helpful.